there's no doubt that there's an awful lot of migraine in children, and depending where you go and we get your figures, the numbers will vary. And like anything, when you're measuring it, it's a question of what you measure. Are you picking up the mild ones where they're only having 1 year? Are you picking up, or are you picking up the more severe ones that are coming to specialised clinics? So it's always a question of how wide you spread the net. Are you picking up the odd migraine here or there, or the odd misdiagnosis as well in there? But certainly, I see migraine and what we call migraine equivalents from infancy upwards. The younger they are, the harder it is to diagnose. Diagnosing these in little children can often be quite difficult because they can't talk to you. There are different syndromes in children, but by and large, the outlook for migraine in children is stable, in that many of them will grow out of it, and the treatments are fairly similar to what happens to adults by and large, although we tend to be a lot more conservative in children about using medications, and certainly using long-term alcohol medications to be a lot more conservative than maybe in the adult population. So there's what's different. We see more vomiting. Headaches tend to be shorter, very severe headaches, but shorter. Diet is a factor, but maybe not as big a factor in children as in adults. And we have these things called migraine equivalent syndromes, where the really headache isn't a big part of them, as far as we can tell. And we'll talk a little bit more about that. Figuring out what's going on may take a fair bit of detective work. And also, we probably may spend a bit of time just making sure that there's something else going on, something bad going on, particularly in little children. So, these are the rough figures that you get when you look at surveys from pediatric clinics or people presenting to pediatricians and pediatric neurologists with headache. 40% presenting with an aura, 55% without an aura. Then there are these other things, the migraine equivalents, which I'll talk a little bit about. Basilar migraine, where there's loss of consciousness, hemiplegic migraine, where there's weakness down that side. Ophthalmoplegic, where the eyes can become, or eye movements can become paralysed. And acute confusional migraine, which I do see quite frequently in children, where you get an acute episode of confusion. So how do we diagnose it? So one of my standard lines in the clinic is diagnosing migraine is not done by tests, as you all know. It's done by getting the story right and taking the history. And if there are enough typical features, then you'll have a diagnosis of migraine provided. And that's where I come in, is just establishing that there isn't anything else going on, there isn't anything bad going on. And that is often my main role with many of these children. So they have the typical features which I'll go into. They're normal between attacks. Family history is important, not essential but important. Normal examination. And where everything fits, they don't need a bunch of tests, they don't need a bunch of scans, etc. If everything fits very well, diagnosis, that is enough in many, many cases. There's a chap called Arthur Prinsky, who I worked for in the States, and he was famous because he had famous for many things. He had developed these things called the Prinsky criteria for childhood migraine, which were the first criteria for diagnosing migraine. And he said, okay, if any three of these six, if they're one-sided, if they're throbbing, if there's an aura, if there's relief by sleep, there's nausea or vomiting or tummy pain, or family history of migraine, you're in. You've got childhood migraine. So those were his criteria, and they have been modified a bit with the subsequent criteria. The migraine with aura then was if there was one or other of these particular symptoms, not more than an hour. The visual, which many of you here know, the zigzag lines, the flashing lights, the blurred, the dark vision, dizziness, unsteadiness, and a variety of other neurological symptoms, which I won't list all the various neurological things that can happen in a migraine. Many of you may know them. Migraine without aura, so we don't have any of these visual and neurological symptoms, so you don't have one of the very good clues that tell you it's migraine. How do you make the diagnosis? Well, you've got to have a list. You've got to have enough that you pick off the list. And the current criteria are at least 5 attacks that fulfill these criteria. So the duration being longer than 30 minutes, maybe not longer than 48 hours. C is 2 of these 3, either unilateral, pulsating, which is throbbing or worsened by exercise, and 2 of those 3. And D is 1 of A or B, either nausea or vomiting, or unable to tolerate vomiting or headache. So essentially, if you pick enough of those off the menu, and you have somebody with recurring headaches, they meet criteria for diagnosis of migraine without aura. And that's generally generally how we operate, but obviously you're coming to see me and looking for all kinds of other features in the story to exclude other things and examining them carefully to make sure there's no neurological abnormality. So the migraine equivalents in children get a lot of press. These are the syndromes where headache is not really a big part of presenting feature, at least if they have a headache, we don't know they have a headache, maybe they're too young to tell us they have a headache. But in general, when they can talk to us, they have much less headache. When they grow up to have more headache, but at this stage in their lives, headache is not this big a feature. Firstly, abdominal migraine, which is the tummy, a recurring stomach pain presentation, with or without vomiting, usually don't have headache, or the headache is mild. Lots of visits to doctors, not necessarily to me, because I'm not a stomach doctor, so a lot of them might go to general paediatricians or gastroenterologists or to their GP. But it is well recognised that many of these children with recurrent abdominal migraine can go over to have full-fledged migraine when they're older, and that this is a migraine equivalent. Cyclic vomiting, again, I would see some of these children where they're having episodes of very severe vomiting, and many of these children can become dehydrated as part of these vomiting episodes. They may be drowsy, they may be confused. Again, for me, this is a diagnosis of exclusion. There are a lot of other things you want to exclude in a child, tummy problems and neurological problems in a child who's having this repetitive vomiting. And none of these children arrive at this diagnosis without being looked at very carefully from a medical point of view. But that is often the final diagnosis, and that approach is taken that this is a migraine equivalent, and we're treated on that basis. And again, with time, they can grow into more obvious migraine features, and we've certainly seen that. Benign paroxysmal vertigo is a rare thing, but again, it's something that has come back to me with fair regularity over the years. You have a child who becomes frightened and unsteady, typically a toddler, somewhere in the age of 2 years upwards. That lasts for several minutes, completely normal in between. And again, that's not something that I would likely take as, oh, this is benign paroxysmal vertigo, next please. It's something that kind of story I would look into fairly carefully. But if we did the workup and we were still happy that that was what it was, then we would proceed on that basis. And again, as a variation on this, quite a different syndrome really, as the child with paroxysmal torticollis. So torticollis, what is that? It's a paroxysmal head tilt, where the head is going to one side. Torticollis is essentially leaning your neck to one side. So this child is perfectly well in between, but then has these episodes where the head is gone to one side, nausea, a lot of vomiting, and been going for hours up to days, happen in infants and toddlers. This is a diagnosis of exclusion. Again, it's not something that I would say, bang, that's what it is. I would look into it very carefully. But again, these children may go up to have a lump. So I'm going to take you through a very informative case history of a child that I took care of over a number of years. It came to me first when she was 7 months old, and this is what she was doing. She was tilting her head to one side, would go on for hours. Sometimes there would be vomiting, but this thing was a big problem. It was happening every 3 weeks. Every 3 weeks, she was having 48 hours where she was miserable and her head was going to one side and she was vomiting. So it was quite a disabling thing. I have to say, most children with this is much rarer. It's once a year. We don't need to do much about it, but this was a child where it was a huge problem. So we did loads of tests. We looked for various body chemical disorders. We did brain scans, etc. They were continuing, and we tried a number of medications, some unsuccessful and some where we had dramatic relief. So we found something that worked for her that stopped these things happening every 3 weeks and worked well until she was 19 months old, and she'd come off the medication somewhere in that time and then had a severe recurrence, and then we tried something else. And as she grew older, vomiting wasn't a big feature at the beginning, but vomiting became a big feature, and we tried her on a new medication, which again worked. Now, I want to stress it's very rare, and I can count on one hand of the time I've used these medications in little children, but this was a situation that warranted it. 3.5 years, took her off everything, she seemed to be doing okay, and then she came back, more with a vomiting. And then, when she was 4.5, she was having stomach pain, up to 3 to 5 days. Again, she was growing out of the paroxysmal torticollis into the cyclic vomiting, into the paroxysmal abdominal pain, and now, at age around 14 years, she's classic migraine, and I don't have much contact with her anymore. She's been gone. They're managing the migraine very well. So this is a 22-month-old that I saw long ago when I was working in America. Again, walking since she was 12 months, but then suddenly having these episodes where she was totally unsteady, couldn't walk, go for a day at a time, sometimes nausea, sometimes vomiting associated with this as well. She had this other migraine equivalent syndrome called benign paroxysmal vertigo. So what else do we see in children? We do see hemiplegic migraine, where the hemiplegia being where it's a stroke-like thing, where there's weakness down one side. And hemiplegic can be just part of regular migraine, but it can also, there's a familial hemiplegic syndrome with a gene identified, and we pretty much know what that gene does and how it works on the cell. It's been very instructive in terms of how migraines work and how they happen. Confusional migraine I mentioned earlier, where we get these acute episodes of confusion related to headache. Hemiplegic migraine, rare enough in children where the eye becomes paralysed. And basilar migraine, where you get these blackouts, collapses. Basilar, the word basilar comes from the particular artery in the brain that supplies the base of the brain, and that's in particular an important area with regard to consciousness. So the concept being that if you had in that region, if you had a migraine